Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Today I will be presenting an overview of the diverse imaging spectrum of pediatric drug toxicities and exogenous toxins. This is a modified version of an educational exhibit that I presented a couple of years ago as a pediatric neuroradiology fellow under the guidance of Dr. Susan Blazer, and I would like to begin my talk by expressing my sincere gratitude to her. I have no disclosures. The main objective is to be familiar and able to recognize the neuroimaging patterns and mechanism of brain injury, and the relevance of clinical history, differential diagnostic considerations, and role of follow-up imaging. Due to time constraints, I'll be focusing on a selective category of toxicities, and these include chemotherapy, immunosuppressive agents, antimicrobials, antiepileptics, hypernatremia, maternal substance abuse, heavy metal poisoning, and teratogens. For further details, I would encourage you to review the current imaging literature. Pediatric brain maturation is a dynamic process. Drug toxicities often manifest with acute neurological condition requiring prompt management. The imaging findings can be overlapping due to common mechanism of injury, and at times they tend to have specific features due to selective vulnerability of different brain regions. So starting with methotrexate leukoencephalopathy, it is an essential drug in the treatment of childhood leukemia, and disruption of folate homeostasis and or direct neuronal damage results in brain injury that typically occurs 2 to 14 days after initiation of therapy. The most common pattern observed in the pediatric age group is that of acute toxic leukoencephalopathy. On MR imaging, confluent T2 and flare hyperintense signal changes are noted in the periventricular deep white matter with true diffusion restriction that eventually resolve on follow-up imaging. Although not specific, it has been described in other chemotherapeutic and immunosuppressive agents such as cyclosporin, 5-fluorouracil, and fludarabine. The disseminated necrotizing variant is seen in patients receiving high doses of intrathecal methotrexate and concomitant whole brain radiation. In addition, the subacute combined degeneration that resembles vitamin B12 deficiency on imaging is also noted in patients receiving intrathecal methotrexate. Atypical and unilateral lesions can be confusing and often mimic transient stroke-like symptoms with or without aphasia, encephalopathy, and seizures. Predominant basal ganglia involvement is an uncommon presentation and without relevant clinical history can be misinterpreted as metabolic disease, viral or paraneoplastic autoimmune encephalitis. Relevant clinical information along with laboratory investigations help in excluding other etiologies, and follow-up imaging also can assist in making the appropriate diagnosis. So that brings us to a very relevant question. Why don't all kids develop methotrexate toxicity? The mutations in the genes that have been mentioned on the slide alter the pharmacokinetic profile and make them more vulnerable to develop methotrexate neurotoxicity, and hence a specific subset is more prone or is vulnerable to develop the chances of methotrexate toxicity. PRES is a cerebrovascular autoregulatory disorder and a common pathway of brain injury involving several chemotherapeutic and immunosuppressive medications. Hyperperfusion with breakdown of blood-brain barrier and fluid extravasation, potentially containing blood products or macromolecules, causes cortical or subcortical edema. The typical imaging pattern includes asymmetric or symmetric cortical and subcortical hyperintense signal changes on the T2 and flare sequences and involves predominantly the parieto-occipital lobes. Frontal lobe and posterior fossa signal changes are not that uncommon. Identifying the triggering event and timely management results in complete resolution or with minor residual signal changes. However, the presence of diffusion restriction, deep grain nuclei involvement, hemorrhage, parenchymal and leptomeningeal enhancement are atypical imaging findings. These also reflect the severity and are not completely reversible on follow-up imaging. L-asparginase is another drug that is used in the treatment of leukemia resulting in coagulopathy and requires frequent laboratory monitoring of hematological profile. The overall incidence of venous sinus thrombosis is between 1 to 3%, and up to 2% of patients treated with this drug develop hemorrhagic or non-hemorrhagic infarcts. The complications frequently occur during the induction phase or within the first 2 to 3 weeks following therapy, and prompt diagnosis by MRI and MR venogram is vital in preventing thrombotic complications. Metronidazole is a commonly used antibiotic for protozoal and anaerobic infections. The proposed causal mechanisms include Purkinje cell damage, inhibition of protein synthesis, and axonal degeneration that is induced by semiquinone and nitroanion radicals that are produced by the drug. The clinical presentation often begins around 2 weeks after initiation of therapy and with doses exceeding 2 grams per day. Children with pre-existing hepatic derangement are more susceptible to develop complications, even at lower doses, and is clinically characterized by seizures, encephalopathy, ataxia, and peripheral neuropathy. The typical brain MRI findings include T2 flare hyperintense signal changes with diffusion restriction involving the splenium of corpus callosum, symmetrical signal abnormalities in the dentate nuclei, the midbrain, dorsal spons, specifically the vestibular inferior colliculi, superior olivary nuclei, facial and abducens nuclei, and the dorsal medulla. Typically, complete resolution of signal abnormality and improvement in clinical symptoms is expected in a few weeks after discontinuation of the drug. Isoniazid is a commonly used drug for treating active tuberculous infections and also as a prophylactic medication. The central nervous system toxicity may manifest as epileptic seizures, sleep disturbances, cognitive dysfunction, and irritability. Disruption of vitamin B6 metabolism reduces the inhibitory levels of GABA, thereby leading to a neuroexcitatory state. On MR imaging, symmetrical T2 or flare hyperintense signal changes are noted with diffusion restriction involving the thalami and dentate nuclei and can often mimic metabolic, para or post-infectious etiologies and osmotic demyelination. The thalamic and dentate signal changes are due to intramyelinic edema that reverses after discontinuation of medication. Now that brings us to a very relevant question. Why don't all kids develop isoniazid toxicity? And the answer is the NAT2 gene that is vital for isoniazid elimination. Genetic mutations in this gene predisposes the slow acetylators to have a prolonged plasma half-life and thereby neurotoxic manifestations. The half-life of isoniazid in slow acetylators is more than double that of rapid acetylators. Vigabatrin is an effective first-line therapy for infantile spasms and refractory complex partial seizures. Symmetrical T2 signal and diffusion restriction changes are visible in the globi pallidi, thalami, dentate nuclei, and the dorsal brainstem. The transient brain changes are due to intramyelinic edema caused by dose-dependent increase in the concentration of GABA in the brain and is seen in 20 to 30% of cases and more common in children less than 12 months of age. Concentric narrowing and non-progressive visual field defects have also been observed in older children and is due to accumulation of GABA within the retinal layers. ACTH has been employed in the treatment of infantile spasms. However, it is associated with a number of potentially serious side effects, and these include hypertension, metabolic and endocrinological abnormalities. The brain shrinkage is dose dependent and reversible upon discontinuing the medication. Reversible splenial lesion with diffusion restriction is a routinely encountered non-specific entity in radiology practice and can be either associated with anti-epileptic drug toxicity or withdrawal. However, there is an extensive list of differential diagnoses, and that predominantly includes viral encephalitis, hypoglycemia, demyelination as some of the differentials. The exact mechanism in seizure-related conditions is unknown, but often postulated to be due to excitotoxic injury or intramyelic edema or a combination of both. Pediatric hypernatremia is an under-recognized imaging phenomena. The mechanism of hypernatremia is not well understood, but is quite similar to osmotic demyelination associated with rapid correction of hyponatremia. The myelinating white matter tracts and deep gray nuclei are more vulnerable. Brain parenchymal and intraventricular hemorrhage are attributable to capillary fragility and endothelial injury. Due to common pathophysiology, the imaging spectrum of hypernatremic dehydration due to accidental and non-accidental salt poisoning are indistinguishable from one another. In the next few minutes, I'll be briefly touching upon the implications of maternal substance abuse on the developing pediatric brain. Cocaine and amphetamine act as CNS stimulants. The cytotoxic effect on the tropoblastic tissue affects early fetal development and resulting in premature birth with germinal matrix and intraventricular hemorrhage. In addition to prematurity, elevated catecholamine levels lead to vasoconstrictor effect on placental and fetal vasculature, resulting in multiterritorial infarcts. Maternal alcohol abuse can impact the growing fetus at different stages by inducing structural brain changes and altering postnatal neurobehavioral development. The posterior fossa, and in particular the vermis and cerebellar hemispheres, are more susceptible for alcohol-related injury. Dysmorphic faces, microcephaly, callosal abnormalities, cortical volume loss are some of the other well-described features of maternal alcohol abuse. Human toxicity of mercury varies with the form, the dose, and duration of exposure. Inorganic mercury, also known as calomel or sweet mercury, is traditionally used in teething powders. The elemental form exposure includes cutaneous and central nervous system dysfunction. Tremor, insomnia, memory loss, neuropsychiatric and visual disturbances, peripheral neuropathy, and ataxia are well documented clinical presentations. On MR imaging, very often the findings are non-specific and include brain atrophy, T2 hyperintense white matter lesions, and there is also involvement of deep gray nuclei described in sporadic case reports. A high index of clinical suspicion and toxicology screening is vital for diagnosing and preventing further complications. Retinoic acid is a widely used drug in the treatment of cystic acne. The teratogenic effects depend on the timing of exposure during gestational period. Maternal consumption of oral retinoic acid in the pre and early gestational phase carries a risk of approximately 20% of having a child born with evident congenital anomalies. Retinoic acid embryopathy mainly affects craniofacial structures, heart, thymus, brain, and cranial nerves. Alteration in the Hox gene expression is detrimental to neural crest-derived structures, resulting in labyrinthine and midbrain hindbrain patterning defects. Other well-known associations include supratentorial, craniofacial, and cardiovascular malformations. Misoprostol is a synthetic analog of prostaglandin E and is commonly used to induce abortion, specifically in many Latin American countries. In cases with unsuccessful abortion, vascular disruption and increased uterine contractility are the proposed mechanisms of injury resulting in prenatal brainstem ischemia affecting several cranial nerve nuclei. Ischemic necrosis and calcification of the facial and abducens nuclei can manifest as Mobius syndrome. To conclude, when we look at this slide, which shows varying patterns of diffusion and T2 flare signal changes, differential diagnostic considerations should include pediatric drug toxicities because these can mimic several neurometabolic disorders. Clinical history, follow-up imaging, and relevant laboratory investigations are essential in reaching a specific diagnosis. Early recognition can alter the clinical management with a favorable neurological outcome.